All right. Hello, good afternoon or good morning from wherever you are joining us here today. My name is Jen Braun and I direct the AHA team training program. Welcome to today's webinar on teamwork and malpractice. What's the connection? So before we begin, just a few rules of engagement. We've been on Zoom quite a bit over the last 2 years, but just a few reminders. Audio for today's webinar can be accessed either through your computer speakers or through your phone. And there's a way if you click the microphone button at the bottom of your toolbar to toggle between the two. So just keep that in mind. Also, all of your lines will be in a listen-only mode. And so for Q&A during today's webinar, we encourage you to chat in your questions for our speaker, Dr. Feldman, throughout the webinar. Anything that's content related and related to his presentation, I will save for the end and we'll do a moderated Q&A. If you have any logistics or technical issues, feel free to chat that in throughout and we'll respond in real time. So just a few other items of note is this session is being recorded and will be posted on our webpage. You will be notified when it's being recorded in case you want to go back and listen or share with others. And like I said, utilize the chat throughout. I do want to call out that you can either chat to everyone or you can change the chat and speak to or chat with an individual or to just the hosts and panelists if you have a question that you just want us to see. So just wanted to call that out there. For continuing education credits, we're happy to have CE credits for this webinar. Please note that you have to do a one-time setup. We get our CEs from Duke. Kara just chatted in the instructions. You need to create a Duke OneLink account. Like I said, this is a one-time only thing. If you've done it in the past for our webinars, you won't have to do it again. But the instructions Kara has chatted in. Once the webinar is over, I will share this number and this code again at the end, but you'll need to chat in that JORNES to the 919 number there after the webinar is over. So we will share that again towards the end of the session. Finally, just a few upcoming events I wanted to share. We have 2 webinars in the month of May, and we will chat in some of those details here. You should be able to click on the hyperlink. They are active. So we have 2 webinars next month, and then we're really excited to have our in-person 2-day Team Steps Master training courses return since before the pandemic. So we're really excited to get back in action. We have several centers across the country and dates you see there. So if you'd like to send a team to one of the courses, registration is open. We also have a virtual workshop series that is kicking off next week on managing conflict in healthcare. It's once a week for 4 weeks, and it's led by Sana Henninger. She's one of our AHA team training faculty members from Duke. And she's done a couple webinars in the past and has done an excellent job. So we're really looking forward to this workshop series that is virtual. So we have several education offerings coming up. So again, we will chat in that information here shortly, but we hope you will join us. So enough of me. I would really like to introduce our fantastic speaker today, Dr. David Feldman, who's the CMO of the Doctors Company. David has been on our AHA team training advisory panel for a number of years and has been an awesome partner of ours. So we're really excited to have him. So enough of me, David, please take it away.
Great. Thanks so much, Jen. Can you hear me okay?
Yes.
Excellent. So welcome, everyone. Delighted to see everybody here. Well, not see everybody, but be with everybody. And I really am looking forward today to spending some time with all of you to talk about the concept of teamwork training and malpractice. And, you know, most people in healthcare, they hear the word malpractice and they really want to run the other way. It's not something that, you know, is a warm and fuzzy thing, but I'm hoping after today's session that you'll agree that there are some potential benefits for us in the world of healthcare, understanding malpractice and how we can leverage malpractice and malpractice data to really improve healthcare, reduce risk, and really make the workplace a better place to be as well. So these are the things that I'm going to generally focus on. I'm going to explain a little bit about our so-called 3P model, the impact of communication, and teamwork on malpractice rates, and then maybe some interesting tips for you on how you can take this stuff back to where you are and make something of it using this malpractice data. So here's my little agenda for today. We're going to divide this up into sort of 4 pieces. Start by talking just about malpractice in general. For a lot of healthcare folks, this is not so old stuff. It's not old stuff for a lot of people. It's fairly new, and I hope I can enlighten you on some of the things that I think are most important to understand about malpractice as a healthcare provider. We'll talk about malpractice data and teamwork and some of where we see this in malpractice data. We have some interesting things to show you about that. The patient, where does the patient fit into this whole equation of teamwork and malpractice? And then again, something about how we engage leadership and insurers on helping us leverage this. So we're going to start with a polling question. I think it might be a good way to get you all sort of get the juices flowing, if you will. How do you feel about the role of malpractice in improving patient safety? Do you already use it and you want to use it more? Do you think it's probably useful, but you don't have access? Do you think it's too rare an event to make it meaningful? It's too arbitrary to make it useful, or you just don't really know enough to be able to answer the question? Tell us what you think about this polling question. And we'll have Kara bring up the results when we have enough folks. All right. Let's see what you all said. Pretty good mix here. A good number of you aren't really that knowledgeable about it. I hope we can change some of that today. Some of you think it's useful, and others say you're already using it and you'd like to use it more. Excellent. I think that's a great start. So let's dive right in. We can take that off the screen if you don't mind, Kara. So this is really, hang on a second here. Here we go. This is kind of how we think about where a lawsuit comes in this whole sequence of events when things go wrong in healthcare, right? So there's an adverse event. Many of you in hospitals have risk managers, I hope, and those folks in risk management might send an alert, that is, let somebody at your malpractice company know that there's been an event we think it might end up in a malpractice case. That's probably a good practice, letting people know early. There's lots of things you can do to mitigate these things if your malpractice folks know about it early. But then you're going to go, obviously, on this other side. We're going to talk to patients and family. There's going to be an investigation. Typically, risk management or their colleagues will be involved in a peer review and or root cause. We know the differences, right? Peer review more about what peers, physicians, or other providers think about the care. Root cause really focusing on systems issues. I think they're both important because invariably with these events, there's combinations of both of these things going on. Then your quality improvement folks, if they're different, in many big places they are, they'll have to deal with the reporting to the usual bodies, the state, CMS, the Joint Commission, develop a corrective action plan, which I think we all are familiar with. This whole, the VA put out this really lovely way of looking at corrective action plans. It goes everywhere from education all the way to system fixes. And then I love this feedback loop to the patients and family, letting them know what happened so that they can feel like there's been some movement to try and prevent this from happening again. And the patient safety folks in a hospital will often get involved in some of these corrective actions. And then on the bottom, we have the big bad people in the lawsuit, right? When this happens, and I think most of us know that, at least in the US, most of these cases are either dropped or dismissed or settled. Very few malpractice cases go to trial because of the expense. We could talk about that a little later if you'd like, but this is what we often think of as this path to a lawsuit. This is our 5 minutes for healthcare folks on your law school for the day. I am not a lawyer. I never went to law school, and I don't even want to play one on TV. But this is, I think, some basic knowledge about understanding how malpractice happens. You need these 4 pieces, really, to have a viable malpractice case. There has to be a doctor-patient relationship. I think that seems obvious, although these days, sometimes it's not so clear. There's a doctor-patient relationship. When you have a a telemedicine situation where one doctor is asking another opinion about a patient in one place and the patient is not in another? Does that remote doctor have a relationship with that patient if they render an opinion? It's a great question. I'm not sure I can answer that directly. Sometimes they do and sometimes they don't. But it's not so clear sometimes whether there is a doctor-patient relationship. Is there a breach in the standard of practice? And the one thing I will say about malpractice that I think does make sense, when you look at the standard of practice, it's a community standard. They're not looking at textbooks. They're often not looking in the medical literature. They're going to find out from experts who practice in that community what the standard of practice should be for that specialty during that time under those circumstances. And that is the breach that is going to be held theoretically against this practitioner. Cause means that whatever it is that breach was, whatever you did or didn't do, actually caused the damage, which is the final piece. And there does usually have to be some kind of damage in order for there to be a lawsuit. I'll refer later on in this talk about ways that sometimes that doesn't seem to be happening, but it really is pretty unusual for there to be a lawsuit when there's no damages at all. It's very hard to bring a lawsuit if a patient has a problem, but they don't really have any consequences as a result. Doesn't mean it wasn't a bad thing, but it's very hard to have a lawsuit. This is one of my favorite slides. One sentence definition: malpractice is a violated duty causing harm or unreasonableness. So if you have to think about one word, think about malpractice, unreasonableness, as a way to really understand what's going on in the world of malpractice. This slide comes from a colleague of mine that I work very closely with who oversees claims for our New York office. And what he talks about is this retrospectoscope that plaintiffs' attorneys will find out about something that went wrong and then try and work backwards to try and make the case. It's the so-called retrospectoscope. And I think most of us are aware that the best way for people to defend themselves when this happened is the medical record. It's documentation. And we'll talk more about the role of documentation in malpractice when I show you some of this data. But this is why documentation is so important. They're trying to make a case based on a bad outcome, but they don't really have all the other information. It's the documentation that really is going to help. So this is really a fascinating piece of research that I came across a number of years ago. People often ask, does this work? Does the medical liability system work? In what it's supposed to do theoretically, one of the goals is to actually identify cases where something was done wrong and compensate patients for it. So this was a study done. They reviewed about 1,500 claim files from malpractice companies across the United States. Not actually, ours wasn't involved in this. This is about 15 years ago. 1,500 claims were reviewed in a central location by physician expert reviewers. So of course, the first question they asked was there an injury? Were there damages, right? Not surprisingly, 97% of the time there was. Now you might ask, how could you possibly have a lawsuit, much less win a lawsuit, if there's no injury? As I said, sometimes these things are a little crazy. Little junior doesn't get into the preferred kindergarten. Mom and dad think there must have been a problem during the birthing process, and they bring a lawsuit against the obstetrician. Seems kind of ridiculous. These things do happen, though. They're pretty rare. And the good news is, in the legal system, when that happens, most of the time there's no payment. Why would there be any payment at all? Most of you probably know the answer to this. It ends up being a business decision. The cost of getting experts and attorney fees and all the rest of it sometimes are just a lot bigger than what the payment could be. And as a business decision, they'll often make payment. But most of the time, and these were very few cases anyway, no payment was made, and that's good. So we look at the cases where there was an injury, then the question, of course, is, did we make an error? Critical question, do we make an error? And 63% of the time we did, 37% no. So 2/3, 1/3. You would expect if we made an error paying, there should be a payment made. And the fact is that 3/4 of the time there is. And then no payment in 27%. And of course, the opposite true. If there was no error made, we really shouldn't be paying for most of those. And we don't, again, for about 3/4 of them. So if you summarize this, if I were to summarize it, I would say the system works reasonably well. It's not perfect. It gets it right about 3/4 of the time. It's very expensive, very expensive. The average cost of defending a claim, even when no payment is made, can be anywhere between $50,000 and $100,000. If there's a trial, you can double or triple that. Lots of money involved just in the defense. It has nothing to do with the payments that might be made to the patients, claimants. So how do we think at the Doctors Company and Healthcare Risk Advisors where I work, how do we think about reducing malpractice risk? Well, my colleague, Peter Colbert, who I referenced before, and I came up with this P model. What is the 3P model? Well, basically, simply enough, the easiest way to avoid malpractice is just prevent adverse events. Now, I'm talking to a few hundred healthcare people who are probably laughing, going, that's ridiculous. And you're not wrong, because we know we can't prevent all adverse, right? In 2022, maybe it's 50%, depends on what part of medicine you're looking at, but we certainly can't prevent all of them. Some things happen, either just bad luck or patient's disease. We all know why these things happen sometimes, despite our best efforts. But the fact is, even when there is an adverse event, it's still pretty unusual for there to be a lawsuit. Lawsuits are still pretty rare, even when there is an adverse event. What is it about those few times when there is an event and a lawsuit, why does it become a lawsuit? What's that second P? How do we preclude a malpractice case in the face of an adverse event? And I think most of you know the answer to this. It's really about communication. And we're going to talk a little bit more about that as we go forward. That's what this whole talk is about today, is teamwork and communication, right? So communication, in this case, communication with patients and families. I had a mentor tell me during my training, my residency training in plastic surgery, that when you talk to patients before surgery about complications, that's informed consent. When you talk to them after surgery about complications, it's an excuse. We need this continuum of communication, developing a relationship with patients to really give it our best shot at precluding a malpractice case in the face of an adverse event. Unfortunately, some events are so bad, so devastating for patients that even the best relationships, communication in the world are not going to preclude the malpractice case. How do you prevail? How do you win the lawsuit? And we've already talked about this. It's about documentation, right? So prevailing in lawsuits is about documentation. So for us, the 3 Ps are about reducing adverse events, improving communication, improving documentation. And that's really everything we do in reducing malpractice risk. So let's talk about where teamwork plays a role in this. I'm going to get to my next question here. What do you think is the biggest reason for malpractice cases? What's the biggest reason? Let's go to the polls here, Kara. Biggest reason for malpractice cases: poor clinical judgment, unintended adverse events, bad teamwork between patients and providers, bad communication between providers and patients, or poor documentation. The biggest reason for malpractice cases. All right, what do we have? Bad communication between providers and patients. Excellent. So a lot of you, I think, are headed in the right direction. Obviously, you could argue that a lot of these things are behind it. As I said before, I think the communication piece is often why events become malpractice cases. But let's talk a little more about this. Thank you, Kara. So I think we all know that teamwork, we have not solved the teamwork problem yet. That's why we're all attending these webinars and conferences, right? And this is an interesting series from the New England Journal just a few years ago in 19. I highly recommend it. That Deborah Molina edited about what are these problems that go on? Why are we having these issues with teamwork? I think it's a fascinating way of looking at it, but it still is an issue for us. I think if we look at where people are trying to understand this best, and this comes from Vanderbilt, they have a professional conduct policy, they do training, and they have reporting systems that allow both patients and coworkers to report physicians, other providers that are not communicating well, that are behaving badly, if that's the right term. It's a reporting system, and they now have millions of these reports to glean from. And it's very interesting. If you look at, this is the more recent part of this program, is the coworker observation reporting system, right? What have they found? This is one of the first articles they published on this. These are the kinds of reports that coworkers would make about their coworkers, about colleagues, physicians, and so forth. So you have, is it about medical care? Is it about responsibility, integrity? Look where the big numbers are. Disrespectful and offensive behavior was the biggest category. I think that tells us something about what our coworkers are most concerned about and see more often than not. It's this disrespectfulness. between coworkers. And why does this matter? The same institution, they took an interesting look at NSQIP data. I think most of you are familiar with this. This is risk-adjusted morbidity and mortality after surgery at time 0. And then you can see the surgical outcomes to the right. And they looked for the 36 months before the date of the surgery at the number of reports that were made against this surgeon. And it looks like there's a pretty significant relationship between the number of these reports and the number of bad outcomes. And this is just an example of it, right? The nurse who said, I asked for the procedure timeout, Dr. X said, look, we're all on the same page here. Let's get going without this timeout nonsense. Not really teamwork related behavior, right? And here's some interesting data to show this really does impact patient outcomes. And I think we all can imagine why that is. Very important stuff. This comes from Crico, the company in Boston. Many of you know they have one of the largest malpractice data repositories in the country. We participate in it, almost a third or more of all the claims in the country. And this is a report they did a number of years ago, looking at where teamwork, communication, and malpractice intersect. You can see in this chart on the left, these are what they call contributing factors, the risk management issues behind the claim. Communication is about 30% of them, and the bubble size is actually the dollar amount of the claims. But focus more, 30% of the cases had a communication issue. What I highlighted for you on the right were the issues in the different parts of the healthcare system, ambulatory care, inpatient care, ED care, where the communication was between providers, the teamwork related communication. So here you have an ambulatory care, unprofessional behavior, responsibility is unclear. In the inpatient side, reading the EMR, problems between different types of providers reading the EMR, reaching consensus. And in the ED, hierarchical issues. I think we all know what that is, right? So these are all the places in malpractice claims where we're seeing teamwork problems, and it's a significant part of the malpractice profile in this large database. Let me show you how we take this 3P model and apply it for some high-risk specialties and where this whole teamwork and communication piece fits in. So this is 3Ps looking at a surgical set of claims. And obviously for surgery, the adverse event can be technically related. It can be judgment, pick the wrong operation or the wrong way to do it. It could be patient's disease. We've talked about that. It could be systems issues. These are some of the things, what we call the contributing factors. This is the same taxonomy I just showed you. These are the different types of contributing factors that go into the cause of an adverse event. And I've highlighted for you the ones that may have some problems with teamwork. A misidentified anatomic structure. Surgeon's not operating alone. Where are the assistants, the scrub nurse? Do they see an anatomic structure that misidentified? There's opportunities here. And then just flat out communication between providers about a condition, closed loop communication. These are terms you're all familiar with. Supervision of house staff doesn't always have to be about teamwork and communication, but I suspect many times it is. These are the other Ps, by the way, the preclude lawsuit, right? Inadequate response to patient concerns. This is about communication between patient and providers, and we'll talk about that later. And of course, the defend part is the documentation issues. Let's look at another high-risk specialty. Let's look at OB. I'm sure all of you would identify with that. What are their issues when it comes to, again, the first P, adverse events, and teamwork, communication between providers, patient assessment issues, patient monitoring. Having spent the last 10 or 11 years in the malpractice world as a surgeon, I will tell you, I've been incredibly impressed with how OB is so teamwork sensitive and it's teamwork dependent. It really is in some ways more than in surgery. So look at all the opportunities here. I like to call them opportunities for us to avoid lawsuits when we focus on these things: delays in consults, patient monitoring, communication among providers, again, supervision of house staff. Again, when we look at the other Ps, here it is again, communication with patient and family, and then the whole documentation piece around insufficient, inconsistent, inaccurate. I think you get the picture with that. Final example, emergency department, another high-risk place to look. Again, not surprisingly, lots of opportunities to see where adverse events can be avoided by improving teamwork, ongoing assessment, failure in delaying a consult, communication about condition or failure to read the EMR, supervision of house staff again. Notice not much in the way of the second P. ED docs really have a difficult time when you think about the opportunity to develop that relationship. It just isn't there. There's not enough time to do that. So I give them a lot of credit for making those attempts. And the same thing, documentation issues with the ED as well. So I think this gives you a sense of how we can take malpractice data for a particular high-risk specialty, divide it up into these contributing factors, these 3 Ps, to identify where the opportunities are to improve teamwork and potentially avoid an event and a lawsuit. This is a specific way that our friends at CRICO have developed the so-called ED process of care. It's just a collection of those contributing factors that make sense when you think about the experience of an emergency room patient. From the time that the patient notes a problem, they go to the ED to get care, there's an assessment, ongoing assessment, testing, and so forth, transmittal of testing, consultants, all the way down to the patient actually adhering to the plan. And here in this middle column, this is from a study they published some time ago, looking at the percent of cases. Obviously, there's more than one of these things in every case. It adds up to more than 100. But where are the most common places for there to be problems identified in these lawsuits? I've highlighted the ones that probably have issues with potential teamwork, right? Look at this, 43% development of a discharge plan, consultation management, ongoing assessment and monitoring of clinical status. Is the team talking to each other? Are the doctors and nurses talking to each other in the ED about going back and reassessing the patient, documenting that you've done a reassessment, and so forth? So lots of opportunities here. This is a very interesting study that was just released last year. Again, looking at this set of CRICO data from the IPAS Institute. They do great work on handoffs between team members. You can imagine how that can impact things. They really looked at a set of about 500 random claims from this Candelo, this same database I've been referring to. Lots of claims. They picked out 500 randomly. And again, looked at the kinds of things I've just been telling you about. All the problems that can exist between team members, communication errors. What is it they're miscommunicating about? Severity of illness, handoffs, contingency plans. The percentages represent the percent of these 500 claims, random claims, where there were these issues between staff. 26% of them were between staff. The rest obviously were between the patient and the provider. But just look at the ones among staff, 26%, and those were twice as expensive. The mean cost per case, $359,000. That's the payment made to the patient for those claims that involved a communication problem between providers compared to those where there was a communication problem between the staff and the family. And furthermore, what they thought when all of these handoffs, that 3/4 of them could be prevented with a handoff tool, of course, like the IPAS tool that they have. I think we're all familiar with that, but that's sort of the solution to this problem. But it's a direct link between malpractice and communication. I think it's really critical study. So let's get into the second part of this and talk about where the patient fits into this whole equation. And I'm going to ask you a question I suspect you already have formulated an answer to this. You now have become experts. But let's go to this question anyway. What do you think the best way to engage with patients is to avoid a malpractice case? And Kara, you can bring up this next question. Is it to use good informed consent before a treatment or procedure? Is it being sure to console patients after an adverse event happens? Is it explaining treatment options in detail with patients and family together? Is it using shared decision-making, a great tool that's really, in the last number of years, become a more popular, I think, a terrific tool to really engage patients in making treatment decisions? Or is it really about maintaining an ongoing relationship with patients before, during, and after treatment, whatever that treatment is? What do you think the best way is to engage with patients to avoid malpractice? And I know you're all experts at this already, so shouldn't be a long question to answer. Okay, let's see what we have. So 2/3 of you said maintaining this ongoing relationship. So I guess everybody's paying attention. That's great. Not that these other things are wrong, obviously not. But I think this best encapsulate this continuum. And it's interesting. You could take the question down, Kara. Thanks. It's interesting. There's a lot of talk about this term disclosure. And although I'm not opposed to disclosure, obviously. I think the problem with using that term is that it just focuses on talking to people after something happens. And I don't think that's sufficient, as I mentioned before. I really believe it has to be this continuum, which makes it so difficult really for physicians that work in an environment where they don't have that opportunity, like emergency medicine physicians and so forth. So something that I think is really important when you think about the potential impact for malpractice. So let's keep going. Here we go. This comes from that same Vanderbilt group. Now we're going to talk a little bit more about the patients and their role in this whole teamwork and malpractice continuum. This is an old study, the first one to really show the relationship between unsolicited patient complaints. We talked before about complaints that came from coworkers about behavior. This is about complaints from patient, unsolicited patient complaints, direct relationship between those and lawsuits. Not surprising given all the information we've talked about, right? If the patients are complaining that these doctors aren't listening, they're not paying attention, you sort of can guess that if there's something goes wrong, it's more likely that there's going to be a lawsuit. But this is the first time they really have the data to show this. And you can see this is 20 years old or more already. So it's been around for a long time. Here, what I did was, this is that study I showed you before that just came out in 21, where they looked at those 498 random Candelo claims from the IPAS group. These are the issues they saw between, now this is between the providers and the patients and families. And I like to put up our Team Steps logo here with patient, family, and care in the middle, right? That's so important. These are all the things that they found in malpractice cases where patients were sort of left out of this teamwork, this teamwork model, right? Contingency plan, diagnoses, severity of illness, medication plans, results from tests, radiology, labs, specialist recommendations, the need to see a specialist or primary care physician. All of these were missing in lawsuits. Did it cause a lawsuit? I can't say that it caused a lawsuit, but it's hard to imagine that it didn't have a role in why the patient might bring a lawsuit. And it really is a core part, I think you can see and would agree, of what we think of as teamwork training. And this comes right from team structure in the Team Steps module on team structure, right? Strategies for involving patients. I think it is so critical to involve patients in our teams. And it includes all these things, including in bedside rounds, handoffs, giving them tools, involving them in committees, enlisting patient participation. And one of the things, we've talked in the last few years about what could possibly be any silver lining of this horror show of the last few years. And I think this whole ability to communicate in many different ways has really given us some more tools to do that. Telemedicine, I think everybody understands, is not going back to the way it was pre-pandemic. There are people who are now using in ICUs tools like an iPad or an iPhone to be able to include patients' families when rounds are being made so that they don't feel left out if a family has to work or they can't get to the hospital or they can't get in the hospital, as the case may be. So these are ways to keep patients and families engaged, keep them part of the team, that are so much easier to do now, that I think there's, I shouldn't say this, but there's really no excuse not to keep patients and families involved in their care. And it's a great recipe for avoiding a lawsuit. If that has the impact on you, then that's what I'll say. And then, of course, there are responsibilities for the patients and families themselves. I think you're all aware this comes from that same module. They need to give us complete information, comply with the standards of care, with the prescribed plan of care, I should say, asking questions, managing family members, following instructions, and so forth. But I always am reluctant to emphasize this too much. We can't be blaming patients for bad outcomes, but we do need to include them in the care and make it reasonable for them to help us take the best care of them. I think that's maybe a good way of thinking about it. Okay, so in our last 10 minutes or so, I want to talk a little bit about what you can do given all this information. If you believe my premise, that there's an opportunity to use malpractice in a positive way. I know the idea of saying the word malpractice and positive in the same sentence somehow offends your senses. I apologize, but I do think it can. What can you do? What do you need to know to try and up your game where you are in using malpractice as a way to help you improve patient safety, do the things you are already doing? So let's bring up our next and last question, Kara, if you wouldn't mind. Not knowing a lot about this, tell us what you think anyway. What do you think the best approach might be to get hospital leadership buy-in for patient safety programs? Think broadly. Is it presenting malpractice data to the patient safety committee of the board? Using a well thought out business plan with a defined ROI for all patient safety expenses to the extent you can do that? Having a CFO, a chief financial officer, come to your root cause analyses. making sure the hospital performs well on all publicly reported hospital metrics, or maybe it's getting a dedicated committee, hospital committee, to show your HCAP scores are really as good as they can be, and that will get people's attention for the things you want to do. What do you think is a best approach to engage hospital leadership in your patient safety programs? This is a little larger than malpractice, but tell me what you think. Okay, let's see what you said. Well, interesting. Almost half of you thought presenting malpractice data to the patient safety committee. I guess I should have asked you this question beforehand. Maybe it's the influence of the last half hour. That'd be cool. A lot of you think about this business plan. I think that's a great way to get people's attention. The HCAP thing, interestingly enough, very few of you said have the CFO attend a root cause analysis. Maybe I asked for the best approach, but that's something I used to do when I ran root cause analysis at a hospital I was at for many years. And I really felt, you can take the question down. Thanks, Kara. I really felt it was kind of interesting to have the CFO sitting in a root cause analysis, listening to what goes on. Because invariably, a few weeks later, when the corrective action plan calls for something that has money attached to it, the finance people, having heard this, might say there actually is a patient behind this. Otherwise, it's sort of abstract, It's just a thought. I always thought it was kind of a neat idea to keep the finance folks engaged. And to be honest, I've worked with a lot of finance people. Being in the malpractice world, we interact with them more than I might otherwise have. And I'm impressed by the fact that there are finance people in healthcare when they could be finance people in lots of other industries that are a lot less stressful. So I give them a lot of credit. And I think in some way they're trying to do their part to improve patient care, and kudos to them. It is not an easy place to work, and it's only become harder like everything else. So, but I think trying to engage your finance people with this, I think they're interested. So don't dismiss them outright. I really do think they have an interest in improving patient safety. They do have this bottom line to pay attention to. So they're kind of makes it difficult. This comes from the measurement module in the Team Steps program. It's one of my favorite ways to look at the way we try and improve things. This Kirkpatrick scale, measuring the impact of whatever intervention we are proposing. Sending somebody to Team Steps training, right? Do they like it? Is it useful? That's pretty easy to do. Do they learn from it? I think that's also fairly easy to do. When we get to these higher levels, it's tricky. How does teaching people in patient safety improvement techniques like teamwork training, how does that transfer to their job? How do they actually use that to change their behavior? We did some interesting work a number of years ago after helping a lot of the hospitals we work with train their surgical teams in Team Steps. We created a tool. We had surgeons, anesthesiologists, and nurses, a group of OR folks from our hospitals, get together and say, what are the 9 or 10 most important tools in the 25 odd tools in all of Team Steps that we can observe and give people feedback on? Are they transferring to the job this behavior they learned in a Team Steps course? And they picked 9 of these things, and we put them into an observation tool to be used during the observation of a timeout, which is as good a proxy for teamwork as there can be, certainly in the world of surgery. It happens all the time. I think we all know it happens to varying degrees of quality, but it does, I think it happens pretty much all the time. So we had people watch, actually both in person, and one of our hospitals had remote cameras. We published some of that work a couple of years ago to look and see whether people were using the skills that they had learned in the Team Step course. And could you even use that method, that metric, to see if teaching them this stuff actually made a difference in how they actually acted? It's powerful stuff. I'm certainly happy to send you the references if you'd like, but that's level 3. Level 4, of course, the most meaningful. Are you getting results? In this case, we know what the results are. It's improving patient outcomes. And ultimately, we tend to focus a lot on this. I think it's important to keep in mind some of the level 3 stuff, maybe the process measures, if you want to call it that, are important as well. There's survey data. A lot of studies that we participated in have used survey data to try to help promote the things we're doing. I like using a combination of all of them. I think it's helpful to have pieces of all of them, especially when you're looking retrospectively. You don't have the benefit of a randomized prospective study. the gold standard, if you will, as many kinds of data as you can, I think really makes your argument all the more stronger. So these are the level 4 outcomes mentioned in this module, in the measurement module of Team Steps: patient outcome, clinical process measures, and I'm just gonna throw in my own here, right? Malpractice data. Why not use malpractice data? It's a little trickier, but let me tell you why I think there's some importance to that. And I think how you can use the data, what data you're going to use that's pretty specific for communication and so forth, right? But let's look at this. This is a study that will be published in JACS, Journal of the American College of Surgeons, later this year that we did. Now, here's the thing. First of all, this is 10 years. The one thing I will tell you about malpractice, it is a lagging indicator. It's the last thing you're going to look at. There's lots of power to it, but it's the last thing. So we looked at being a surgeon, my thing, we looked at retained surgical items, and we know in this first bullet here, how do you prevent retained surgical items? It's a combination of things, right? Obviously counting, critical, the most important thing, we do that forever, traditional. Teamwork, you got to have this teamwork going back and forth, radiology, and new technology. In particular, we implemented in our hospitals over a period of a year or two things. Team Steps training, I mentioned that. We trained all the OR teams in all these hospitals in Team Steps, and we also implemented RF technology. It's not true radio frequency ID. We put chips in all the soft goods. So every lap pad, sponge, towel has a little chip in it. It's passive. So when you wave this wand over this towel, it beeps. It doesn't tell you what chip number it is. It's not unique. It just tells you there's a chip. So now you have both counting, traditional, and you have detecting. Engineers would call this depth of defense, right? It's redundancy. And does it work? Well, so we looked at over almost 1 million operative procedures in all of our hospitals over this long period. Implementation in the middle, right, of both Team Steps and RF. This is only this retrospective, this association. Decrease in retained surgical items from 11 to 5 events per 100,000 operations. Even more interesting, the RF detectable items, that is the soft goods, the sponges, lap pads, towels, from 5.2 to 1.3 events per 100,000, and the number of malpractice claims in those dropped dramatically as well. So I think this is interesting data to go and say we should adopt RF, teamwork, some combination of the two. You could argue that in this case, probably the impact was probably more for the RF than the teamwork. You don't really know, given the fact that the most impressive results came from reducing the retained sponges and lap pads. That is only what RF addressed, nothing else. So I think that the take-home message is it's not perfect, but it's an interesting way of looking at results, incorporating malpractice, because the money is significant. People have said a malpractice case involves a retained sponge. Well, it really isn't a malpractice case, it's a settlement. One of the Latin words I've learned is the event itself. It's pretty hard to defend leaving a sponge in somebody after surgery, so usually there's a settlement. But you're talking about $500,000 a claim, more or less, depending on where you look, what part of the country you're in. That pays for a lot of chips and sponges and a lot of team training. So that's the nice thing about this, if there is such a thing, it's the money. So here's some interesting points to be made about this, right? Two things I would say about malpractice that make it so powerful, even though it's small numbers, admittedly. One, the dollars are unbelievable. I come from New York City where the dollars are crazy. We're the most expensive place in the country, the most dollars in payout practice anywhere in the country for a variety of reasons. But the dollars are significant. Across the country, it's probably in the range of $300,000 to $400,000 of payment to the patient for an average claim where there's a payment. Most of the time there isn't a payment, but when there is, it averages around $300,000 to $400,000. And then, as I told you, you got another, $50,000, $60,000, $70,000 of costs, of expenses, paying for legal fees, experts, and so forth. Very expensive proposition. So you don't need too many cases to make the ROI case to say, we have 10 of these things, they cost $1 million each. Can we spend 10% of that to try and fix it? The details that you get for malpractice claims, all of us have participated in root cause analyses, myself included. And, we still struggle with this for a variety of reasons. That's not the topic of today's conversation. We can talk more about why RCAs are not maybe as robust as we'd like them to be. When there's a malpractice case, people bare their souls. They talk about what they were doing that day, what the impact of their family life was on how they were feeling, the fact that the doctor was yelling at them, or the nurse was uncooperative, or the patient was violent, or whatever it was. Some of those things come out in root cause analysis. They all come out in a real malpractice case. So the qualitative details, I think, are really important. That's what gives us the ability to have the detail that I showed you in some of the claims analysis. And of course, we know that malpractice is the tip of the iceberg. As I said, if you have one or two malpractice claims about something, the likelihood is there's a lot more of those events that they just never became malpractice claims. And it pushes us to look for those things. And then finally, one of the things we're trying to do is combine the malpractice data with all these other pieces of data we have access to: adverse event, patient and staff complaints I showed you, outside, all these things. We make expansion out. There's so many opportunities to put all these things together to really make some really meaningful analyses out of this thing. I would encourage you to do that. So, in my final sort of slide or two here, how do you do this? Well, the first thing you need to understand about malpractice is in the United States, it's all state-based. I live in New Jersey. I work in New York most of the time. The laws are completely different when it comes to malpractice. Every state is different. They change a lot. Well, with the pandemic, they're changing day by day. So understanding where you are, the environment you're in, the venue you're in is critical. And it's very different for individuals than it is for doctors, for hospitals, I should say. Some of them have their own policies. Lots of doctors have their own policies. Lots of doctors that work in hospitals, they don't have their own policy. It's covered under the hospital policy. So you need to understand some of that. And typically the risk management folks in hospitals are really good. They're experts at this. They understand this. They understand the laws. There's charitable immunity laws. Some states have laws that say you can't sue a hospital for more than a certain amount of money. That's a big deal when you compare to states that don't have that. Caps on non-economic damages we know about. Some states regulate, New York is one of them, premiums that you can charge physicians. So if what you want to do is incentivize people to participate in a safety program by reducing the malpractice premium, sometimes you can do that and sometimes you can't. Depends on where the malpractice is coming from and what state you're in. So understanding those things will be really helpful in figuring out leveraging this thing in the right way. Get the data from your carrier. I mentioned national sources. I've talked a lot about Candelo, the CRICO database from the community comparative benchmarking system. The MPLA, many of you are familiar with, they have the data sharing project, another large database nationwide. There are slight differences to them, but they're both useful in understanding national malpractice data and sometimes being able to benchmark yourself. So this is what we've covered. Malpractice and risk reduction. Hopefully I've given you a little bit of a primer, if you will, for a non-lawyer on what malpractice is about, what you need to have malpractice, and what the nature of malpractice is, where it fits into our whole adverse event continuum, if you will, how we look at risk reduction through the 3P model, and then taking that and using that to analyze malpractice data and where teamwork fits into that. I'm demonstrating to you today that it is an important and critical part, and you can easily tease this stuff out to see where exactly teamwork fits into this whole malpractice scheme in that 3P model. The patient is important, obviously, critical. When it comes to teamwork, they're a critical part of the team, and they also can be seen in some of these malpractice claims. And then finally, how do you take this stuff and go to your leadership and use it to leverage the things you always have tried to do and have struggled with to make it easier for you so that malpractice becomes net positive. That's the right term. So just some key takeaways again. It can be useful as a tool to identify events, associated costs, and so forth. Poor teamwork, we can see these in these analyses and its specific impact on payment. And then risk management folks and safety leaders in healthcare should understand the nature of malpractice because it can be helpful in how you reduce costs and how you can improve patient safety and teamwork and communication. So I will stop and turn it back to Jen for our last 10 minutes of Q&A. Jen.
Yeah, thanks, David. Great presentation. I think you made it very easy to understand for someone who's very far away from that world. So I appreciate that. A lot of compelling data and just really sound, rationale about how teamwork can help impact this. So a couple questions. I'm going to go to my notes here. You definitely touched on this in terms of evidence where organizations who have implemented team steps have seen fewer malpractice claims. So you shared that in your ORs and that data. Are you familiar with other organizations that have seen team steps implementation and then a decrease in their claims?
Yeah, well, here's the problem, Jen. First of all, there's no way to do a prospective study, right? So it's all going to be retrospective. And like every other retrospective study, it's all an association. I didn't share with all of you, but we did an analysis. As I said, we did across some big institutions in New York, teamwork training for the entire OR staff. And then we took the Candelo, the CRICO database that we have, and looked at before and after the teamwork intervention, not just retained surgical items, everything. And we try to figure out, so what kinds of claims would we expect teamwork in the OR to prevent? And that would probably be claims where there was a problem in the OR. And when you look at surgery claims, more or less, half of them are what happens in the OR, half outside the OR, either before surgery, inadequate preparation, or after surgery, failure to rescue, somebody has a problem and nobody can identify it and the patient has harm, right? But the ones that happen in the OR, how many of those can be attributed to bad teamwork? You would expect those kinds of claims to decrease. And we did find that. Now, are our other hospitals, major academic institutions in New York, doing other things to improve that? Of course they are. So it's hard to say. That's the problem. That's why what I would do is combine that with data that show every one of our CMOs signed off that every member of the OR team took this training, right? And then doing these observation tools. So when you put it all together, I can look you straight in the face and say, I think it made a difference, but it is hard to quantify, no question.
Right, especially when you're doing, like you said, other, initiatives
Of course.
surrounding that. It's hard to pinpoint. Yeah, those debriefs.
Right.
Really,
exactly.
Yeah. So I understand. It's very complex. And the person that chatted that question, and I had shared that I'm aware that Metro Health, one of our partners, our Team Steps partners in Cleveland, have implemented Team Steps system wide. And I know initially when they were, pitching it to their leadership to bring Team Steps in, they calculated the cost of, litigation and malpractice. And it was, upwards of $1 million. And then they quantified that for training a certain department in Team Steps. And that's how they started to kind of gain some momentum and get that yes from their C-suite. And then they also found, and again, I don't have like the hard data, but they report that they've seen a decrease in their malpractice. So I shared that case study that talks about their very high level implementation, and that was one of their outcomes. So, and then a question, you talked at one point in your presentation how, there are a lot of Team Steps tools, like 20, some of them, and then you guys drilled it down to 9 or so some of those tools that you really felt like could get the biggest bang for your buck. Can you talk about that or recall what maybe some of those tools?
Yeah, sure. And I'm happy to share the reference to the paper. It was published in, I want to say 16 or 17, that looked at that very tool that lists all 9 of them. But this is critical now. These are the things that the folks in our hospitals thought were the most important. And sort of like a checklist in some ways, right? That may not be a one size fits all. For them, they felt these were the things that demonstrated that timeout was a great example of teamwork when they did all these things. They identified who the members of the team were, right? They identified the patient's problems. It's the elements of a timeout checklist, if you will, using Team Steps language, right? Everybody introduced themselves. I don't remember them off the top of my head. I used to have them off the top of my head, but I'm getting older now. I have no room on the top of my head, obviously. But I'll be happy to share the reference with you. All that information is there. Feel free to use it, but keep in mind, it's always good to have your local folks decide, is that what they think is important? Yeah.
And I think you hit on a big, that's a webinar for another day, but the concept of ownership. So, this is the problem. This is the task at hand. We're going to be doing Team Steps. Here it is. What works for you? You are going to. So what tools or how can this fit into your day-to-day, into your world? So I think that's a really great point. I think we'll do one more question here. So beyond training, what best practices have you seen among leaders at all levels in modeling effective communication with their frontline staff?
Yeah.
As a leader.
As a leader, right? So look, I think the most important thing to model is respect. I can't say it enough.
Mhm.
I give a talk on creating a culture of safety, and the first part of it, I did this at the last in-person AHA meeting, I think back in 19.
Yeah,
Dare I say?
before
Maybe
the
that
world
was
shut down. Yeah.
had one since. You've had one since, maybe.
Mhm.
But talk creating a culture of safety. The first is respect. You have to model respect. Without that, I mean, there's a group that maybe some of you are familiar with, Vital Smarts. They've written books on crucial conversations, crucial confrontations. That was my intro into a lot of this. And they've used the term silence kills. If you don't talk it out, you act it out. I mean, it's so true. And yet in healthcare, it is so difficult because it's a high stress environment. And we're under high stress as human beings. What is our instinct? It's fight or flight. None of those work very well in a healthcare situation. So the first thing I would say to model as a leader is being respectful. And it doesn't matter who you're talking to, whether it's a colleague, a nurse, a physician, a therapist, a student, a resident, the people who are delivering the meals or taking care of the janitorial services. It doesn't matter. They're all part of the team. And I've seen plenty of successful healthcare leaders say that is the most important thing, is modeling that behavior. And then holding people accountable. And that's okay. There's a lot, we're all thinking about this horrible case, Redonda Vaughn, with this nurse that's, been convicted of a crime for a medical error. And, without a just culture, that means holding people accountable and punishing people for reckless behavior, but certainly not for human error, not even for things that are risky. It's education. So I think modeling a just culture and having your policies back you up is critical to sending the right message that we care about what you say. We want to hear from you. We're going to hold you accountable, but not for things you can't control.
Great. Thank you. That's a great way, I think, to end today's webinar on that note of respect. I think that's a great answer to that question. So before I let everyone go, just a couple quick logistical reminders. Please note that the evaluation form will appear on your screen once we end this webinar. So we really value your feedback. So please complete that for us. And then finally, again, for continuing education, please create a Duke OneLink account if you've not done so already. The instructions have been sent in multiple times. It's on our website. And then once we conclude here today momentarily, you can text JORNES to that number there to claim your CE credits. So with that, I just want to say thank you so much, David, for an awesome presentation and being a great partner of ours for so many years. We really appreciate you and all the work that you do. So I would like to, again, thank you all for joining us here today, and we hope to see you next time.
Thank you, Jen. Stay well, everyone.